So just on to the final session before lunch. It's my colleague Fiachra Bane, a head of data analytics in the healthcare pricing office, to speak on pricing developments and some ABF myths and misconceptions. Thanks, Fiachra.
Thanks, Brian. Just before I start, they say you learn something every day. What I learned today is never give your presentation to your boss before you go on, because I talk about stealing your thunder, Paul. You've seen half of this already. One thing I will say, he's got a good eye for quality. So today I'm just going to talk a bit about pricing developments and some ABF myths and misconceptions. So just in terms of what's happening in terms of pricing, the 2023 ABF price list was published online in quarter one. We have the hard copies available here today, and should be on your packs. We probably have a few extras out on the desk if needed. As Brian would have mentioned, it hasn't been used for ABF budget setting purposes for the last few years because ABF has been on a COVID-induced hiatus, but it is using to instill in ABF reporting, cross-border directive, procedure tendering assessment, and that whole process has still been really, really useful in terms of the work we do in the National Finance Division. Just to flag that the 2024 price list will be moving to AODRG version 10. The current one is version 8. To go along with the price list, we have the 2023 pricing framework. Last year was the first year that we put out the pricing framework that really sets out the principles behind how we set the prices, and a lot of the sort of technical information about that. So that is on the website currently. Have a look. It clearly flags what changes have happened in the model, and that the intention of this document year on year is mainly to flag changes and developments in the models as we go. To go with both of those, then really we have a 2024 pricing framework consultation paper. So this year is the first year that we've actually put out a consultation paper. What we want to do is get feedback from all the stakeholders on the topics that we're considering for the 2024 price setting process. So that submissions are going to be taken between essentially today, 31st of August, and we will address as many of those as we can in price setting for 2024. The topics that are covered in that document are individual DRG prices, so anything that's in the price list, the adoption of a common weighted unit. I think Brian goes up me on that one as well. Funding model calibration, transition adjusting roadmap, the ICU funding model, and model-based hospital adjustments. So just to give a very brief dip into each of those, the price list, it's been published for quite a number of years. There are 800 DRGs, and I think in total there's about 3,300 odd individual prices set. Nobody's really going to be able to keep on top of all of those. So what we're asking is the system have a look at these, particularly in relation to PLC data. If you can point out where you think there might be prices that are, not correct or need to be adjusted, we can look into that with the national PLC data and see whether, something needs to change on those. One thing I would say is that capital and depreciation are out of scope for ABF. They're not included in the prices. So if you are making a submission, make sure that it's not the capital side of things that you're referencing there, because we won't be able to do anything on it. The admitted patient weighted unit. So I think anybody who's kind of worked with the ABF data to date will be aware that yes, there's a weighted unit for inpatients and day cases, and yes, they are two different things, and you can't just add them together. What we're proposing from 2024 is to just move to a common admitted patient weighted unit. The benefit of that will be literally you can just take your whole admitted patient services, add them together, and you're getting a more holistic view of what's going on. Just to give you an idea of what it is, I mean, the base price is essentially the average cost, across inpatients. So it's 6,101 on the inpatient side this year. Day cases is 934. We have done the work, and that the work on the admitted patient weighted unit has been in the background for many years. what would happen is there'd be a common weighted unit of 2879, which would be the one. So that is going to be a bit of a change. I think we're quite used to, around 1,000 for a day case, around, $6,000 for the inpatient. Um, but I think the benefits of this are there, and we can always roll back. You will always be able to get back to your separate inpatient a day case one. But I think our default position should be the admitted patient weighted unit. Funding model calibration. This is a nerdy one, so I'll go through it briefly. There's a bit more detail in the document, but essentially, when we generate the price list, it starts off from the patient level costing data, which we have for, I think, maybe about 20 hospitals participating in that at the moment. But we fund 43 hospitals through ABF. So we have to find a way of taking this very granular level information for PLC that allows us to set DRG prices and make sure that at the overall level that the cost equals the value. When we've done that over the years, we do it separately for inpatients and day cases. And what we've noticed in the last few years is that there's kind of distortions coming into the model. So there's a particular calibration step where there's essentially a departure from what PLC is saying to make it fit to what specialty cost is saying. When we did the pricing model and the benchmarking for this year, we actually started looking into this, and we reran the 2021 benchmark under both ways, and actually discovered that if we do this calibration to total cost rather than inpatient and day case separately, the model fits so much better. And solves a lot of the issues that we find with some specialist hospitals and things like that, where you tend to get very high or very large deviations from what the model says. So the proposal there is that we will change that calibration step. I know it's quite a technical piece hidden in the model, but it does very much improve the performance of the model in terms of the fit to the overall hospital costings. The transition adjustment roadmap. I'd like to compliment Brian on his nice table there in his presentation. So this is the proposal again. That I think when we left off before COVID, it was 87.5% was where we were at, and the proposal is for 2024, that transition adjustment will be 85%, and it will move down to 75% by 2025. So really, what that is saying by 2025, hospitals will be exposed to 25% of the adjustments, either positive or negative, from the benchmarking exercise. We've also done some work heavily hampered by COVID in relation to ICU funding. So at the moment, ICU activity is essentially bundled into all of the DRGs and not really focused on those hospitals that have level 3 and level 3S ICUs. So we did a good piece of work. It's up on the website now in relation to, well, what really are the cost drivers? What potential model could you put in place that would give you a complexity adjusted per diem, particularly for ICUs, so that it would still form part of the ABF model, but it wouldn't actually form part of the DRG payment. It just means that the value would be directed more accurately to those hospitals with those units. So where we are with that, we've done the micro costing work, and we've reported on that. We have what we believe is a workable model, and we're just currently working with NOCA then to develop a transfer of the audit database that would support. HYPE currently doesn't have the level of information on ICUs required to run a model like this, but the NOCA ICU audit data does. So I don't think it's something that's going to be in place for 2024, but we will be working on it, and we'll probably have more to report back on that next year. And finally, we are consulting on model-based ABF adjustments. This is probably one that certainly anybody who's involved in case mix back in the day will know. We had 4 hospital groups, and essentially there was a different base cost and base price for each of those groups. So that was the maternities, the pediatrics, the tertiary referrals, and the others. What we started to notice is, and particularly over COVID, there's differential activity changes seen, particularly in the COVID pandemic, where maternity activity was much less affected than other areas for quite obvious reasons. Um, but in terms of an ABF model, that would, and particularly in the benchmarking, it would kind of a lot of value in the model suddenly gets focused onto the maternity hospitals. We also see as well that Model 2 hospitals tend not to have sufficient activity levels to perform well in ABF. So what we feel is that it's worth investigating going back to that type of model where there's an adjuster for the model of the hospital, which we think will again give a better fit and add more stability to the ABF model. Prior precedents in that's what was in place up to 2013 in terms of the case mix adjustments. And it would achieve a similar thing as the tertiary referral adjustment and the pediatric adjustments in the models. So they're already there. In some areas, I think there's benefit in actually rolling them out. So it's something that we're certainly going to have a look at, see how it affects the models, the outcomes of the benchmarking, and then a decision will be made as to whether that's the model going forward or whether actually it really doesn't improve things for us. I believe that will give us some more flexibility and stability in the model. The last document then I just want to talk about is the quality-based funding framework. This one is still in draft form, but I expect that it should be finalized in the next few weeks. So really what it is, I think anybody who's familiar with the hip fracture database and the best practice tariff associated with that. And what we're trying to do in this document is set out the principles and the minimum requirements if somebody wants to go along that route and put in a best practice tariff or something like that. It's something that's been lacking. We do get, and certainly Brian gets, calls from people says we'd like to replicate what has been done in the hip fracture best practice tariff, but we haven't actually had the framework to allow that to happen. So that's really what this document is setting out. We settled on the term quality-based funding, but it's an umbrella term for anything that could really be construed or related to the quality of care for the patient, including pathways, pricing signals, payment for performance, that type of thing. So really just in terms of the principles, I'm not going to go through any depth in that in this document, but really the things that we should be looking to support is clinical best practice, clinical priority. There should be clinical oversight in relation to any such tariff. It's got to be measurable. There's got to be data integrity, funding availability, which is a big one, and at least in my mind, time limited. In terms of minimum requirements then that are mentioned in this document, so there has to be a good clinical rationale for wanting to do this. Could be good governance structure, which we would have in place in terms of the hip fracture database. There have to be good, robust metric definitions. There's got to be payment criteria. How what criteria need to be made for a payment to be made. Good data systems and processes in behind that. Some may exist already, some may require development. What are the assessment criteria? What is the funding source? And again, I'll say a little later on, but the HPO don't have funding to allocate to these type of things. So we need to come with a funding source, whether that's through, acutes or whether it's through a clinical program to identify how that will happen. And also a payment method. Does the payment go to the hospital? Does it go to the service? Is it a combination of the two of those? So those are all questions that kind of need to be considered and answered. And there's going to be a mailbox, just qbf@hsc.ie, that will allow people to make submissions in terms of the quality-based funding. So very quickly, just onto the ABF myths and misconceptions. So one is, and they're kind of related, these aren't kind of standalone, they are related to other pieces that people have spoken about or would speak about later on. So if my activity is not included for ABF purposes, then I will lose funding. Well, potentially you could, but the ABF works on a strict matching principle. So if your activity is in, the costs are in. If your activity is out, costs are out. What really when your activity is in ABF, it's bringing you to the table. That activity is there. You're putting your lunch out. Somebody else could eat a portion of that lunch because it's a zero sum game in that model. It's like one of those financial ads on the air on the radio where you get the little blurb at the end that your investment could go up or down. That's essentially what ABF is doing. Um, if a hospital is performing poorly in ABF, it's unlikely that bringing in additional activity with the associated cost is going to change things because likely the cost is high there as well. We do want to get as much activity as we can into ABF, which is why we're increasing the scope or widening the scope. And just important to say that it's also the converse is always true. If you add in additional activity, it doesn't mean there's going to be additional funding for you. All that's happening is it's going into the pot and it's that efficiency equation versus your peers. Hospital activity, which is out of scope for ABF, is not funded. This is one we hear quite a lot. And I think we sort of mentioned earlier on, approximately 69% of hospital funding is associated with admitted care, and therefore it's in scope of ABF. So that's 31% of that cost, which is in the block, which mainly covers ED and outpatients, but there are other smaller components. The block grant has pros and cons. The pro essentially is that it's ring fence funding. Nobody else can eat that portion of your lunch. It's just for you. The big con for block funding is that we just don't have the granularity and the insight that you can get on the admitted patient stuff, which is because we've got really good systems, we've got really good coding, classifications in that area that we don't have, for instance, yet for OPD and ED. Just for the context, in 2022, the total ABF budget for 20 was 7.2 billion. That is different to what Brian said earlier on. I'm talking about just the ABF hospitals, whereas I think Brian was all the full set of acute hospitals. 5 billion of that was in scope for ABF, 2.2 billion in the block. And I suppose the take home point there is 2.2 billion is a lot of funding to be allocating to services that are not funded. I guess we can make an argument that they might not be adequately funded, or we can't see that each individual section is funded, but they are funded. The HPO have budgeted to fund quality-based funding initiatives, and this is one I think there is a lot of interest in getting some quality-based funding initiatives in place. The HPO are certainly interested in supporting any of these that come along. I guess the hip fracture is the one that's really well known, and that initiative relied on the allocation of specific funding by acute operations. So it wasn't funding that was allocated by the HPO. It came from acute ops. And as mentioned, the QBF framework is going to lay out all of those minimum requirements and principles for this. So hopefully it's going to be a significant enabler to allow us to bring more of these type of initiatives online. AMAU activity receives funding premium over other acute floor type activities because it's recorded on HYPE is included in ABF. This is the one that's responsible for the ABF myths and misconceptions. We were having a call one day and it kind of came back that it was being said that AMAU activity was receiving 10 times the funding that ED activity was getting. I was like, okay, this has to stop now. It's just it's gone to a silly. The rumors have gone to a silly proportion. Just in terms of the background, the AMAU activity was brought on to HYPE simply because there was nowhere else. They were rolling out the acute medicine program. There was no data available, nowhere available to capture that data. So they were approached, can we put this on HYPE so that at least we can see what's going on and we can manage that rollout. So, it was agreed at that time that was the case. Our position is that when there is an acute floor information system and a proper data collection and a classification system, that is where where the AMAU activity should be. Similar with ASAU and other ED type uh, activity. But there has been this perception that on one side that the AMAUs are getting preferential advantage in terms of funding. And B, on the other side, that if they move from HYPE into an acute floor information system, that they will lose out. So we just took a quick look at the figures there, just down at the bottom of the slide here. So if we paid the average cost of an ED attendance to every AMAU same day case, they would actually receive 4% more. So currently they're actually receiving 4% less than they would in a flat cost per case in an ED. Also, but they also happen to be getting 4% more than the cost of treating those patients. So I would say we're pretty accurate in where that would be. The 4% above is just a facet of the inpatient model, and the implicit incentive there to have shorter lengths of stay. They tend to get rewarded, so the cost of value tends to be lower there. Hospital activity which is not recorded on HYPE is not recognized or valued. So I suppose this one comes up quite a bit as well. I'm not talking about recognition in terms of ABF or value in terms of monetary terms, but literally just the people who work in areas such as ED, outpatient, allied health feel that, well, why have we got all this effort, this great knowledge on admitted patients and not in ours? And they feel not recognized or valued. And I think there probably is a case for that, because we haven't developed those classifications and data collections yet. But what I would say is that those are two of the real focus areas for ourselves in the HPO, is to build up those data collections to bring ED and outpatient up to the level of HYPE, so that even, say, for instance, the work that Paul is doing, he's getting that granular level of activity that really describes what's happening in our healthcare system, rather than saying, well, we know what's really going on in this section, but everything around it is a little bit opaque. So it's not that it's not valued or recognized. I think it's just that we're working towards getting those to the same level of recognition that we would have in place for HYPE. Population-based funding will render ABF obsolete. I think the CFO, the CEO, and Brian have all covered this one. So look, again, we believe that the two will work hand in hand. PBRA can determine the amount of funding needed to meet the healthcare needs, but it's very much an input kind of based system, whereas ABF will be still required there to look at the throughput, the quality, the outcomes, and the efficiency of allocation, which is more to do with the outputs of those. And with that, before I get yanked off the stage, I'll leave it. Thanks.